It's a great pleasure to participate, and I'm really sorry I couldn't make it to Athens to this legendary congress. Really, THV has been pivotal for transcatheter heart valve therapies, and thank you, Kostas Spargias, for making that happen. So it's a great pleasure to present the TriClip case. And following on the previous discussion, it's very important that we're now discussing about the tricuspid valve. We all recognize that this is not just a valve disease, it's a syndrome. It affects pretty much every organ in the body. And as we recently had a working group on that, and one of the colleagues said, just walk around in the hospital and do an echo on any female patient above the age of 75, and you will see a lot of TR there. And this is true. Most of the triluminate data comes from female patients with atrial fibrillation, like this one I'm going to show you. So this is an 85-year-old female patient with severe TR, of course, significantly symptomatic, had 3 hospitalizations over the previous year due to decompensated heart failure, mainly right heart failure, but also associated with dyspnea, against the background, of course, of atrial fibrillation, hyperlipidemia, and some renal disease. So as we evaluated the patient, we performed coronary angiography, and that showed no evidence of coronary disease. And the right heart is interesting. There's moderate pulmonary hypertension, as you normally see in these patients. There's some degree of elevated wedge pressure, but still the mean is below 20, which is a typical triluminate patient. Transpulmonary gradient is not huge. And you have elevated right-sided filling pressure. So the mean is 13, the V wave is 24, almost as high as the wedge pressure, but still a preserved cardiac output and not elevated pulmonary vascular resistance. Euroscore is 4.7%, but really I don't know what Euroscore 2 means for this population. So this is the TEE, and I have a couple of shows. So this is an atrial MR. You can see the leaflets being horizontal with some central jet, very big left atrium, no thrombus, small LV with preserved ejection fraction. And this is the money. So this is tricuspid valve, dilated annulus. And you can see on the right, there is some tending of the septal leaflet, mainly in the anteroseptal region and in the central part. But when it comes, you can see on the left, the posteroseptal area is pretty much okay. And this is the 3D MPR view from the mid-esophageal. You can see a lot of TR. And on the tricuspid interrogation, you can pretty much see on the MPR on the top right, the short axis view, the equivalent of transgastric. So it's a truly tri-leaflet valve. That's a good thing. And you can see also the quality of the leaflets on the bottom right images. We were not able to get a decent transgastric view on this patient, and that can be a problem because transgastric is mandatory for these cases. However, if you can get a good mid or low esophageal view and you can reconstruct an MPR, you pretty much have your transgastric view there. And you can see some additional views on that. So this is the amount of tricuspid regurgitation. It's definitely severe. You can say it's massive. I don't know if it's torrential, but definitely it's a lot of TR there. And this is the procedure. So percutaneous access, puncture on the right groin. This is the guide catheter that goes in the middle of the right atrium. Then the tricuspid, it's a tricuspid TSGC, tricuspid delivery system that will come out. It's pretty automatic now to get straddling position. So the TriClip, or you can see on the top right, the fluoro, to get into the straddling position under echo monitoring on the top left. We can see some hemodynamic measurements on the bottom left. And once we reach this straddling position, so we've exposed the TriClip out of the guide catheter, we can flex down to the tricuspid valve, which is very, very fast. So this is a process that doesn't take more than a few seconds really to just flex down towards the tricuspid annulus. And once we get into position, then we can set ourselves into the right ventricular inflow and outflow view. The main thing is to avoid hitting any object, such as the aortic annulus or the septum, and then get positioned above the tricuspid annulus in the region of interest above the collar. and get your trajectory right. By that, I mean have a nice trajectory on the left view. You can see on the echo. You can be in the middle of the valve above the region of interest, but also have a nice trajectory on the right side. So you can see on the right side that the path of the clip is parallel to the septum. So there's no hugging, there's no septal tilt, which usually biases the device and gives us a bad trajectory. Once we get into that position, then we just open the clip arms. You will see in a minute. By opening the clip arms, we will be able to get our perpendicularity right. And then, of course, we will get the grippers. We will see what the grippers are looking like. So I'm just going to accelerate that a little bit. So this is opening the arms. You can see on the fluoro, you will see in the echo in a minute. Once we see the arms open, then we will be able to move the grippers. We test our trajectory, and then we independently move the grippers. And you can see that it was the septal gripper on the right there. And then we quickly changed to NPR for this patient. Normally, we would go down to the transgastric views, assess the short axis, and check our perpendicularity right. But here we did that automatically in the NPR view. We dived down towards the tricuspid valve. So now we are below the leaflets, and we're actually going to grasp the leaflets on the NPR view. So you can see on the top left, the lateral leaflet, the anterior leaflet is already on the arms, and the grippers are down. And then we will just move down to the ventricle, rotate septally, and then we will come up trying to get the septal leaflet flat on top of the arms. Sometimes we test it, so we get it up and then we move down, and then we will go up again like with this move, and we're happy now that the septal leaflet is there. Grippers are dropped. We just cancel the septal rotation, then we lock and close. We close slowly by looking at the echo and recording it. We want to make sure that the leaflets stay in there in the arms when we close. And this is how we did. And it's time to evaluate both on the long axis view, short axis view, but also in the transgastric and fast view, which is now coming from the NPR. So you can see on the top right here, for example, that the anterior leaflet is actually nicely tethered and pulled by the clip, and also the septal leaflet is in position. So by using the NPR, actually, you're able to have a very, very quick assessment of the insertion of the clip and be happy with the leaflet insertion and the stability of the leaflets. This takes a couple of minutes. We also combine that with color assessment. You can see that the anterior part of the jet is gone, but there is also a central towards posterior part of the jet. We also use some 2D to look at the leaflet insertion. And once we're happy with all this, then we will deploy the clip. And this is the clip deployment. By having a fluoro and echo monitoring, we just pull the suture line, which is the lock line. And then I'll just accelerate that a little bit. This is deployment of the clip here. You will see removing the pin and the gripper line in a second. So pin comes back, gripper line comes back, and then the handle comes back, and the clip is stable, is deployed, and you can see on the echo, it's a nice position. Then the plan is to get another clip in the more central rotation. This is even easier compared to the first one because you already have the fluoro marker of the first clip, so you know how to orientate your second device. Nevertheless, you have to check on the echo, make sure you don't touch on sensitive structures, but flexing down and getting your trajectory is actually even easier now because you have a reference point on the fluoro. And we pretty much follow the same steps. You can see now that we're above the clip in a more central position on the fluoro. That means we're coming a little bit lower compared to the first clip, similar to the mitral clip. And once we get into the position, we go to our NPR view. Here we tested the independent gripper movement. It was septal again. We're above the valve. We have checked our trajectory. We have checked our rotation and perpendicularity. And now we're going to move down to the tricuspid valve in a second. to move and check, try to grasp the valve in a more posterior location. Here is the perpendicularity view. You can see that on the top right on the MPR. So we pretty much follow the same perpendicularity that the first clip had, but we just rotate a little bit clockwise to be absolutely sure perpendicular to the coaptation surface of the anterior and the septal leaflet. And now we're gonna move in, we check the trajectory again. We're gonna close the clip in a minute. And we go in slowly with the clip closed, very carefully, close to the first one. As you can see, we're very close, but still quite far away. Just below the leaflets, we open and we're in a grasping position already. And we're gonna continue grasping on the MPR view. So you can see the clip comes back. Already the anterior leaflet is there. We could even go for simultaneous grasping in this particular situation, but sometimes it's worth doing an independent grasping to be absolutely sure that we check things. So the anterior leaflet is already there, and now we're gonna move to the septal part, make sure we get enough leaflet in. We always take care not to rotate the clip, so we check the fluoro to check the rotation. Now the septal is in, and we're gonna close. That septal gripper is down, and then we're closing very, very slowly. And you can see that the clips are parallel to each other. They're not tilted against each other. A little bit rotated to respect the line of coaptation, but they also have the same height on fluoroscopy. And now we're checking the outcome, and you can see now that the most posterior part of the tricuspid regurgitation is also eliminated. There's only mild residual tricuspid regurgitation, which is a good thing. Of course, we're going to check our leaflet insertion in 2D and MPR view. And then this is deployment of both clips. I just accelerated for the interest of time. You can see how the two clips are now released, deployed, parallel to each other, and moving a little bit independent to each other. So probably they have different scallops of the anterior leaflet and they have some independent movement, but nevertheless, they are moving together very nicely. And this is the final result that you saw on the left side. And this is now removal of the guide catheter using the figure of 8. So no closure devices, no need for angiography, just figure of 8 to do your hemostasis. This is the result, some mild residual tricuspid regurgitation. The clips are stable in position. This is what the tricuspid regurgitation looked before and after. It's worth going back. Sometimes we're trying to get the best result, like 0 TR. That's almost impossible for TR procedure. Not sure if it's necessary. TriLuminate put the bar to moderate or less. This is definitely less than moderate. Of course, you know, I'm always open to your opinion about it, but definitely there's a lot of improvement. And it's worth also looking at the pressure tracings. So on the left, you can see the pre-pressure. There was a V wave to 23 with a mean of 10. This V wave was actually truncated completely. It went down to 8 with a mean pressure, RA pressure of 5. So that hemodynamic response is also very encouraging and shows that we've done a good job for this patient. So thank you very much for your attention. And of course, I'm open to discussion and comments and happy to answer.
Thank you very much, Dr. Ninios, for your excellent presentation and congratulations for your work. May I ask you, the device selection has to do with the operator experience, or there are any anatomical findings that might tell you that to choose the one or the other?
That's a very good question. Operator experience is first, cost is second. I'm very sorry to say that, but I want to give a realistic answer. Availability is a third. If I wanted to go down to the anatomy of things, I can say that Pascal is a little bit more forgiving. You have the elongation feature that you go down, you know, if you get entangled in the cords, you can elongate and you can get out. You can also invert and get out with a clip, but clip has got the grippers which are alongside the gripper arm, not at the edge, so you can get easier entangled in the cords, and they are dense cords. That's why we take extra care when we move down to the tricuspid valve, not to go too deep, and that comes with experience. You saw that we just shallow under the leaflets. On the other hand, if you really want an annuloplasty effect, and I think that's quite important, and of course it's anecdotal, it's pure personal experience, but we've seen this paradigm in the mitral space as well, especially in this atrial population or in some extreme tethering in the ventricular FTRs. Clip is very powerful. It can do that. So it can pull the leaflets, it can pull the annulus. We've seen some really impressive annuloplasty effects on the clip, more pronounced perhaps than the Pascal. But to be honest with you, both devices are very, very effective. And actually, if you look at the trials, both Triluminate, BeRite, and PACE registry there are non-randomized comparison, of course, but they give similar reductions, like a moderate or less in around 80 to 85% of this population. So I think that's a good sign.
Thank you. Dr. Spargias?
Vlasis, congratulations. Excellent demonstration of a TEER procedure. My take-home message from this case will be screening a case that will be easy case in terms that it's anteroseptal, the color. But then during the procedure, you have to make a lot of decisions, like where exactly you put your first device. If you put it very deeply in the interseptal commissure, you may not have a great effect in color reduction. So you have to decide how deep. If you put it very close to the center and you need a second device, it might become really difficult because you won't have any anterior leaflet left to grasp. So in your case, I think you selected a very good position in the interseptal. It was not very deep, but it was not in the center of the valve. You had a great effect with your first device. And then your second device, you had to go really close to the first device to be on that short part of the anterior leaflet left outside of the first device and to get this great result. So my take-home message will be that if you have anteroseptal pathology and color, then this is a very good case for clipping, but it's not only that. And you have to decide exactly how and where you have to position the first clip, and then see if you need a second. So if you need a second, you have to, let's say, take measures from before to position the second. And the other thing is that you have to go for the best possible result, but sometimes you have to accept some residual TR in your case, like you said, and congratulations again for this case. The last thing I want to say is that sometimes the cordite is a very important part of the screening that we tend to neglect. And when you go to the procedure and you have some cordite to an area, that creates problems. So, for example, in your case, if you had the cordite in the anterior leaflet in the position of your second clip, it will be impossible. So it's a combination of things, and the GLIDE score is very good because it takes into account all these small details, and it gives you an idea of how successful you're going to be.
Thank you, Kostas.
Are there any questions? No. Just before we close with Dr. Ninios, I must tell you that we are going to have another more live-in-a-box case just now, presented by Dr. Chrysocheris. So don't leave from the room.